Remember, no dummies ahead.
There you go.
Are you ready? Okay, thank you. So I think that we can all here relate to a scenario that's a little bit like this. We have a patient with a chronic condition, let's say for example it's diabetes, and this patient either calls and cancels or just fails their, say, 3 or 4 month checkup. And then about a week later calls back and says, hey, my blood sugars have gone sky high, I'm out of my medications, and now it's a sudden panic at the office. You know, what do we do with this person? Can we squeeze them in somewhere? Do we need to call in some more medication? Then sometimes what we have to do that we don't want to do, but we're forced to, is to say to that patient, I'm sorry, we're not going to call any more medications in for you because you've missed your last 3 appointments. Until you come in here to be seen, we're not going to be able to do that. So I know that I have providers who are frustrated. They'd like to find a better model to deliver care, especially for their patients with chronic conditions, to manage those patients. I know that we have providers who are frustrated at the pressure that's being put on them to report quality to government agencies and to insurance companies, and it's the way that those entities define quality, and our physicians don't like that very much. And I also know that I have physicians that say, for example, would like to be able to pull up a screen that says, you know, this is what percentage of your diabetes patients are at control, whatever the physician says is at control. And unfortunately, we don't have that kind of information at our fingertips, and we would like to, but even with an EMR, we don't. So in all of the chatter that's going on in healthcare reform, there are a couple of terms that are being thrown around as possible solutions to some of these problems, and that's what we're going to talk about. And we do some of this right now in Goshen, especially with the Cancer Centre, but it's really a very determined effort to make that stuff happen. And then with all of the members being jointly responsible for the outcome, everyone then jointly gets to share in the cost savings that can result from doing that kind of work together. And this really directly responds to one of the proposals that's out there, which is that in the future, hospitals will receive one payment for the care of that patient, and then that's going to have to be shared throughout the organisation. So that's really what an accountable care organisation speaks to. The patient-centred medical home as an alternative, not really an alternative, but it really works side by side with that. It's an approach to providing comprehensive primary care and care coordination that emphasises the elements of practice organisation, health information technology, quality measures, and patient experience. And when I think about the medical home, I think about it as this being the way that an entity like Prime Care can really add value to our organisation when our organisation is trying to be an accountable care organisation. So, the first part of this, the health information technology. What they really talk about, they don't necessarily push an EMR. It could be an EMR, but it doesn't have to be an EMR. What they really say is the key in a medical home is having a patient registry, and this is something that we've already started doing out at Shipshawana and at Dunlap. At Shipshawana, we're building, Ingrid has got a long way to building, a registry for our diabetic patients, and she's keeping it as an Excel spreadsheet. She works with Jen, the NCP, to get that information out of the EMR, but she's building it as a separate database, as an Excel spreadsheet. And then we just recently have begun steps to do this with lipid disorders at Dunlap. The next one is quality measures, and you know, we hear this a lot, but the medical home really talks about evidence-based care, and so you are going to see a lot of protocols, standards, goals, all founded on evidence-based care. And then you want to use the information that you're finding in your registry to then go ahead and develop your protocol. So when you develop the registry, let's go back to diabetes for an example, you can begin to see this many of our patients are at control, and here we've got another set of patients who are maybe in a middle ground, and these patients are out of control. And so we're going to develop protocols to meet the needs of those groups of patients to hopefully get more of them into control. Patient experience, we love to talk about same-day appointments, and we know that that's an ideal that we would all like to have, but it's difficult to get there. But that's something that we do talk about a lot in the medical home environment. Personalised care, really helping patients feel like that their care is being coordinated in their primary care setting, and then being taken out and coordinated out with specialists, hospital, whatever other care that they need. Helping the patient feel that they are involved in their decision making, and really helping the patient through education to become invested in their own care. And then practice organisation. This is really, to me, the really exciting element of the medical home as far as the discussions that I've had with my doctors and with Mary and with other members of the administration. Getting a health coach model set up in the office. What we're talking about here really is an additional FTE or funneling our FTEs in a slightly different pattern. This person probably is a nurse. It might be a little bit of a change from what we now think about as a telephone nurse or a triage nurse. But instead of just really doing just plain old telephone calls and triage, they really are involved in getting the patient educated and engaged and encouraging the patient. Helping to make sure that the patient is prepared for his or her appointment when they walk in the door or after they walk in the door before they see the provider, so that you're maximising the provider's time. And so in doing that, really freeing up the providers and the other colleagues to do some of the other stuff. So back to the example that I talked about before, where this diabetic patient has just missed his appointment, get the health coach on the phone with them, talk through why have you missed your appointment, why have your sugars gone, what's been going on with your diet, what's going on with your medications, let's get you in for an appointment. And of course, having that additional FTE costs money, but a lot of studies have shown that you really can begin to drive revenue by encouraging compliance. Entities such as the American Academy of Family Physicians have looked at this and really believe that this is a model that is very worthwhile in investing in. Really gets into. So just to conclude, the patient-centered medical home is an approach to delivering comprehensive primary care, which is being offered as a response to the changing needs of patients and clinics in the healthcare reform environment that we're in right now. Entities such as the American Academy of Family Physicians, the American Academy of Pediatrics, I forgot to mention this, they actually were the first ones that defined medical home, and it was all the way back in 1967. Many of these entities have really advocated for this model, and they're calling for enhanced payment to primary care clinics who engage in this kind of model. So whether or not we see that coming down the road, that'll be interesting. Time will tell. To recap the elements of the patient-centered medical home is your health information and technology. It should be a patient registry, disease registry. It may or may not involve an EMR. Quality measurement obviously being very important and allowing us to then be able to really put our hands on that information that helps us to do better with our patients and be able to report that quality externally. Patient experience, helping our patients to feel like, just what it says, that this is my medical home and that when I need something, I know where I'm going to be able to go to either get what I need or coordinate what I need with other entities. And then the practice organisation, whether that involves the health coach model, there are other models that I didn't go into today, and really just helping our providers and our colleagues feel like they can get the most out of the day and use the resources that we have. With the goal then being to bring about a physician-driven, patient-centered model that uses data to capture and improve quality and compliance while helping patients become engaged in the care of their own health. That's it.